That doesn't happen often, but good evening. So tonight, gonna do an Ask Me Anything. Trying out a new microphone, the Shure microphone. Maybe not as loud as doing the big podcast microphone, but I'm gonna see if this mobile one works a little bit because the other one is kind of bulky and needs a lot more cable. So this is a Lightning port M77 Shure microphone. So if there's major issues with the audio, I'll keep playing around with the settings, but we'll get started here, answering you guys' questions. Had some good ones about lipids tonight. So first question tonight, does pregnancy and breastfeeding worsen LDL particle and ApoB levels? First caveat is that I'm definitely not an expert in this area. Haven't treated a lot of pregnant patients since my fellowship over 10 years ago. So not my area of expertise at this time. There are patients who have familial hyperlipidemia who get pregnant, and they will often, switch some of their lipid-lowering therapies during pregnancy. But otherwise, if you don't have FH and not have a history of atherosclerosis, they may just let your lipoproteins run wherever they're going to run when you're pregnant, and then after you're done breastfeeding, switch it back to whatever lipid-lowering therapy they need to. All right. Questions about any thoughts on Lactobacillus ruderi to help with high absorbers of cholesterol. So, have not seen any data on that particular strain having a major effect on lipoprotein metabolism. If you use the cholesterol balance test from either Empower or Boston Heart Lab, you'll know if you're a hyperabsorber of sterols, particularly beta-sitosterol and composterol. If you are, then medications like ezetimibe would tend to work best. Fiber really only has about maybe a 5% lowering, and I've not seen any data that changing the gut microbiome has a major effect. It's usually an issue with one of the ABC binding cassettes or the Niemann-1-PIC receptor itself. Maybe other benefits for that particular probiotic, but I haven't seen it for lipids. So if you're a good biohacker, get a test pre-taking it, then don't change anything else, take it, and then repeat your labs 6-8 weeks later and see if anything changed. Question about optimal targets of LDL and HDL particle count and size on the NMR testing for a midlife healthy person. So it's always going to be those cases where show me that you're truly a healthy cardiovascular individual, because if you look very fit on the outside, does not necessarily mean your arteries are as healthy. Bob Harper, the gentleman from The Biggest Loser, is a very good example of that. Very fit individual, had a near fatal myocardial infarction in his early 50s, had Lp(a) and ruptured a plaque in his left anterior descending artery. So when people say that they're healthy, to me, as a endocrinologist, that means your calcium score is 0, or if you had a clearly CT angiogram, a very low plaque score in that, you have a carotid artery intimal thickness scan, that is normal, and that potentially you have other testing that looks at endothelial function. So do you have optimal nitric oxide levels, do you have normal blood pressure, normal pulse rate velocity, normal endopat, then you truly are healthy. Then you can get down to looking at what's actually in the blood. So the NMR is the gold standard at looking at the particle number and size. The count is more important than the size of the particles. The size of the particles are often genetically influenced, but also have a large component to when people are insulin resistant. If you're metabolically unwell, you tend to make a lot of small LDL particles. So particles predict risk. The more cargo ships you got floating around your arteries, the more interactions there can be with arterial walls and damages the glycocalyx and gets retained in the underlying artery wall. So always look at the particle number first. The size is more of a metric of, again, your metabolic health, or your insulin resistant. So an LDL particle count number for most generally should be less than 1,000. The HDL particle count, there's really probably not a target, but it's just more of a kind of general trend. If you have high inflammatory markers, particularly myeloperoxidase, your HDL is likely dysfunctional. So if you have low HDL particles, that's often a marker of dysfunctional HDL. HDL has multiple roles in the body. One of the roles is to go into the artery lining and pull out cholesterol from the lining of the arteries. HDL also has roles in the immune system. So the challenge is that you don't really know what HDL is doing. You just can measure the number. And so if you have low HDL particle number, it's potentially more marker of dysfunctional HDL. All right. There's I think one more pre-submitted question, and I saw a couple other questions popping up in the forums there. So, question about what do I see, not including meds, to be the most effective behavior change to decrease LDL? Well, from a dietary standpoint, it's mostly don't be insulin resistant. If you have, insulin over 8, hemoglobin A1C over 5.1, triglycerides over 80, LDL particles, particularly the smaller LDL particles that are high, you're likely insulin resistant, and then work on that first. How do you do that? Focus on muscle health. So muscle-centric medicine, as my friend Dr. Lyon talks about, focus on your high-quality protein to give the building blocks for your muscle, and then focus on your resistance training so that you lay down more muscle units. And then when you're doing your aerobic activity, your GLUT4 receptors are expressed. They basically are like straws. They go out into the bloodstream and pull in the glucose and utilize it for energy. So don't be insulin resistant or reverse your insulin resistance. Second, doesn't happen in everybody, but if you are on a higher fat diet, particularly a higher saturated fat diet, some individuals, their LDL particles really shoot up because it has an effect on cholesterol production in the liver, as well as lowering the LDL receptors. The LDL receptors are like cargo docking stations sit on the outside of the liver, plucking the ApoB particles as they go by. So in that case, stop eating a keto diet or cut back on your carnivore high saturated fat diet, and you'll see an improvement in your LDL particle number. That being said, medications, if they're off the table, supplements, bergamot, red yeast rice, berberine, those are probably the go-to supplements sometimes that can help modulate the lipoproteins. But you need to know what's going on with the arteries, because that really has the kind of the idea of like how aggressive you should be considering lowering your lipoproteins after you've switched the lifestyle interventions up. Question, can plaque fill up the smallest arteries also? What to do when hard plaque is everywhere? So first question, so the smallest arteries generally are the ones that get injured first. When I was an invasive cardiologist, we were mostly treating your coronary arteries that are 4 or 5 millimeters in diameter. They're still very small, but the microcirculation is what provides 99% of blood flow to the heart and the rest of the body for that matter. So you've probably heard me say it before, but you have reportedly nearly 60,000 miles of blood vessels. The majority of your blood vessels are about 1/100th the diameter of a human hair. Another way said that 100 of these microvessels fit in the diameter of your hair. So it's typically those small vessels that tend to get damaged first. The glycocalyx in them gets impacted. It's not so much that the plaque fills up in them, but it is possible. And it's not even visualized. You don't even see it when you're doing an angiogram. So you're mostly just treating the whole vascular system. So support the glycocalyx, optimize nitric oxide levels if they're low, lower oxidative stress, lower inflammation, and then modulate the lipoproteins as needed, often shooting for an ApoB target less than 70 and ideally 55 for many people who have advanced plaque in their arteries. Now to your second question, what to do about hard plaque if it's everywhere? The hard plaque is more of a stabilizing function. So if you have soft plaque, that's the plaque that is more concerning to rupturing and causing a heart attack. The hard plaque can cause symptoms if it becomes occlusive in one of your large arteries for the most part. Typically, you'd have to have a 70 or 80% stenosis in one of your arteries. So I often talk about a plaque as kind of like an iceberg. The majority of that plaque is in the wall of the artery. And after a while, the tip of the iceberg pokes up into the lumen and starts occluding the blood flow. You don't feel it until it occludes the blood flow by about 70%. Once it's there, it's generally not going anywhere. Those patients often will have symptoms, especially with exercise. They have a supply-demand mismatch issue. So if they get the heart rate up to 150, they can't get enough oxygen or blood past the obstruction, and they start having symptoms. Chest pain, pressure, shortness of breath, or just can't do that exercise anymore. They stop, that heart rate slows down, their chest discomfort or shortness of breath goes away. Those patients, if medications don't improve their symptoms, those medications often are beta blockers, calcium channel blockers, long-acting nitroglycerin, then procedures such as angiograms with stents or bypass surgery may be considered, but it's not guaranteed that you're going to need a procedure if you have those symptoms. Secondly, there are supplements and medications that have been shown to help stabilize those plaques and potentially get some of the salt plaques to regress. But again, it's mostly about support nitric oxide, support the glycocalyx, lower inflammation, oxidative stress, and lower the lipoproteins as needed. And then I think there's one more question up here that's pre-submitted. What are my thoughts on THC and the heart? Generally, it's a net negative. Yes, it may help with sleep. Yes, it may help lower inflammation. But from a cardiovascular standpoint, it can increase the risk of atrial fibrillation. It can increase the risk of significant, basically, endothelial dysfunction if it's an inhaled form of THC. The combustion forms of THC are going to be irritating to the endothelial glycocalyx in the lungs and the cardiovascular system. And then, patients don't have a fully developed brain, they're less than 25, and they have a propensity schizophrenia. THC may trip them over into full-blown schizophrenia. So it's not a risk-free option. That being said, you have a history of seizures, your neurologist is recommending it, no concerns there. We'll just have to deal with the side effects of the heart if need be. But the cannabinoids, the CBDs, those can be potentially helpful for lowering inflammation and are generally neutral to heart health for the most part in my experience. All right. So thank you for those that submitted the questions ahead of time, and I'm going to hit the ones that are popping up in the comments here. And I saw a couple of people that routinely pop up in here, so welcome everybody. Somebody also is asking about my thoughts on severe anemia in the heart. First is, what is causing the severe anemia? The acronym I learned when I was in medical school was make them, break them, or lose them. So are you not making enough red blood cells? Is there a problem with your bone marrow? Do you not have enough iron, B12, folate? Are you breaking them? This is not as common, but if you have a mechanical heart valve or something in your system that's breaking them, like sickle cell disease, that could be a problem. Or are you losing them? Are you losing blood in your urine, your bowel movements? So find out why you don't have enough red blood cells. If you're anemic, then that definitely can put stress and strain on the heart. You need the red blood cells to carry oxygen through your system. So if you have significant anemia, in some individuals, that's enough to cause angina. They don't need stents, they don't need medications, they need blood. They need to figure out why they're losing blood. That was a consult we get not uncommonly when I was still around in the hospital. The patient coming with a GI bleed and having crushing chest pain. No, they're not necessarily having a traditional heart attack. They didn't rupture a plaque. They don't have enough oxygen-carrying red blood cells to deliver oxygen to the heart tissue. So they would have angina. Give them blood, their angina got better. So got to figure out why you're losing them or not making them first. Somebody's asking, do they have varying ranges for HDL, LDL, and triglycerides? What do I think are ideal levels for a woman in her 50s? Honestly, sex and age play a role, but not a lot. It's really, what is the health of the arteries? Atherosclerosis starts in your, basically it's in utero in some ways, but clinically present in teenagers and 20-year-olds if you're looking for it. They got fatty streaks in their aorta. So it's for all comers for the most part. In a traditional lipid panel, you're not going to get a whole lot of data out of it. That's going to tell you what are optimal. If your triglycerides are over 80, maybe you have an issue with insulin resistance, or you have a genetic issue with lipoprotein lipase and you have issues breaking down fats. You can figure that out with genetic testing. LDL cholesterol, I don't necessarily have a target goal on LDL cholesterol. I'm more interested in what the LDL particles are, what are faring that cholesterol with the LDL-C. So I'd be looking for an LDL particle count near 1,000. And HDL-C, I don't really hardly look at it much. Because if it's low, you don't know if it's genetic low. There's other markers that can tell you if they're insulin resistant, and that's why it's low. If they had a recent infection, it's going to be low. And that being said too, if HDL-C is high, it doesn't mean necessarily cardioprotective. There's no such thing as good cholesterol. There's just cholesterol. And at times, if your HDL-C is high, over 50, over 60, it's because it's dysfunctional. If you have a lot of inflammation, often if it's the marker myeloperoxidase that's high, your HDL is basically getting damaged, and the liver has to keep producing more and more HDL to replace the ones that are getting damaged. So your HDL-C is going to be higher in your blood test, but it's actually an atherogenic particle. It's actually going to probably injure your arteries. So there's not a number that you want for everybody. So I would look at traditional panels to make sure the person doesn't have familial hyperlipidemia. It gives you some idea if they're metabolically healthy or not, but there's a lot better markers to look for it. So somebody said, do I know an integrative cardiologist that I'd recommend in California, or especially in San Fran? No, I do not. Honestly, I can tell you that there's only very few cardiologists that understand these type of advanced labs and talk about endothelial health and the glycocalyx, and not very many of them are going to be talking about quantum biology, circadian biology. So there's probably nobody who's going to really talk exactly like I do. But if you go to the A4M website or the IFM website, you might be able to look into find a member if there's somebody closer there. But let you know that we have patients all over the country. We've had people from the Bahamas, Canada. We've had somebody from Hawaii fly to St. Louis to see us. So telemedicine is something we do routinely with our patients who don't live locally to St. Louis. All right, so thank you for sharing this one. This is one that, I'm glad guys are open to speaking about. This person says that they're 46 years old, they're on certain blood pressure medications, and they're having some ED issues, so erectile dysfunction issues. But they still wake up in the evening with erections in the night, but they don't work well when they go to use it. Would you say it's hormone issues or heart issues? Well, it sort of depends, one, what blood pressure medication you're on. If it's a beta blocker, it may be the beta blocker. If it's an ACE inhibitor or calcium channel blocker, it's probably not the medication that's doing it. But if you had long-standing hypertension, that could have damaged a lot of the microcirculation to the penis. And you've probably heard me say before, ED equals ED. So if you have endothelial dysfunction, you often will have erectile dysfunction. So I would still suspect that's probably a vascular issue. Hormone issues, possible, but testosterone is much more important for libido than it is per se erections. Now there is some effect on aromatizing the testosterone into estrogen, and estrogen helps support nitric oxide. So there is some effect that testosterone could help with erections, but it's not the primary benefit. So always want to rule out the vascular causes first, and then support nitric oxide if it's low. So you can test salivary nitric oxide with different test strips. I like the MyFit strip ones particularly because it tells you if you're getting enough nitrates in your diet or with your supplementation. Also tells you if you have a healthy oral microbiome that can convert those nitrates into nitrites and then into nitric oxide. Is your blood pressure well controlled on the medications? If you have access to pulse wave velocity testing, that'll tell you if your arteries are elastic. Your arteries should expand and contract like an accordion. If you have access to a test like a EndoPet, that will tell you exactly how much nitric oxide your arteries can release when there's a vascular stressor. So other things, if you're over the age of 40, a CT coronary calcium score. Your score should still be 0 in your mid-40s. If it's not, then you would anticipate it's vascular etiologies, and then start treating the things that are causing the vascular disease. Well, this is a really good one. I'm listening to a podcast that hopefully I have a little bit more response to in a couple days, but somebody's asking about my thoughts on the lean mass hyper-responders while on a keto diet. It's a fascinating phenotype, but it's one of those cases, show me. You cannot just tell me that you're metabolically healthy and an LDL-C of 400 is not going to cause a problem. You can tell me all day long your calcium score is 0, but it may take years for dyslipidemia to cause a calcified plaque. So are you developing endothelial dysfunction? Is your glycocalyx getting shredded? Do you have low nitric oxide? That's stuff I'd want to know first. That you develop plaque in 10 years is interesting, but I want to know, do you have endothelial dysfunction right now? So I know there's a recent kind of headline maker that a guy had been on a keto diet. I think LDL-C is in the 400, tried Crestor, which is a high potency statin, dropped his LDL-C by something like 35%, stopped it, numbers went back up, and then kept on the same keto diet, which was mostly Mediterranean focused is what I hear, like a lot of olive oil, not as much saturated fat as some of the keto diets are out there. And then ate like 2 sleeves of Oreos, and then his LDL-C dropped by 70%. So I think it's more of a party trick than I would say that it's necessarily provative of this lipid energy transport model that they're positing. It's an interesting theory, but it's one of the cases where it's like you're truly a biohacker in that case. You're playing with your own life, and if you're an adult, you have every right to do that. But you can't posit it that it's safe for everybody to do that. So show me that your arteries are healthy, and you can try to keep doing the diet if you like. But I've seen many patients come in following these type of diets, and I show them the arteries are very, very unhealthy. And then they can decide that if they're going to stay on this type of diet, they're going to likely end up on pharmaceutical agents to mitigate that risk, or they can abandon the diet and go to something that's more possible that you could stay on for a lifetime and then not be on so much medications to affect the endothelial function and the lipoprotein. So it's an interesting response. I've seen it many times, but keto diet isn't for everybody. And the quick side note is, keto diets, evolutionary, like you would have never been 365 keto by choice. You were likely only keto in the wintertime in this hemisphere. If you had a season where there was summer and you had access to carbohydrates, you would have eaten them. So you never would have been keto 365. So interesting, but the jury is still out, let's say. Is it dangerous to have painful thumps in your chest? Unknown. I mean, maybe it's premature ventricular contractions, premature atrial contractions, a physical exam, an EKG, potentially a Holter monitor can figure out what the thumps are, if they're actually an arrhythmia or not. All right. So somebody's asking about the Clearly scan. If you're actually interested in having our practice help potentially arrange it, we do an intake because we have to make sure that people are right candidates for this test, that they can take certain medications, that they have normal kidneys, that they're not allergic to contrast. So it's not a test for everybody to walk in off the street and go straight away and get. If you're actually interested in having our practice potentially order for you, it's best to go to my website. It's just drtwyman.com. There's an application in the top. My team would reach out to you and set up a meeting and discuss with you. But ballpark, it depends on where you get the scan done. If you get the scan done in St. Louis, the CT angiogram portion of the test, don't quote me exactly, but ballpark about $600, $650 for the baseline images that the radiologist interprets. And then those images get sent over to Clearly. Clearly uses their AI machine learning algorithms to interrogate the images, and Vox by Voxel looks at the plaque volume in the arteries. So it breaks it down. Do you have hard plaque, soft plaque, and low density soft plaque? That portion of the test, that's paid directly to Clearly from the patient. That test is $750 for that part of the test. So all in, the Clearly scan is about $1,300 to $1,400. Great information. Likely is they think they're going to be the gold standard in the future for anybody who wants to know their vascular risk. But the key, honestly, is once you have that data, who are you going to work with to be able to guide you on what to do about it? Like what caused the plaque if it's present? How are you going to mitigate it? That's really the thing that's the differentiator once you have those results. All right. Well, some great questions tonight, guys. Trying out a new microphone. I heard that at least one person said that the volume might have been a little bit low. I'll play around with it in post-processing. Last week I was using the big podcast microphone, lots of cables, and I couldn't set up my normal lighting, so I was trying to do a different microphone tonight that has a shotgun microphone, so wanted to see how that goes. So I will be back next Monday, 6 p.m. Central Time, same format, ask me anything. I'm starting to work on some longer form videos to be on my YouTube channel, which is just going to be youtube.com @Dr. Twyman. I'll be doing some lab reviews, my own labs, show you how I interpret my own stuff, so people can kind of get an idea of like why I order certain labs. And then last week I was teasing a little bit about having a heart attack, prevention screening kit at home. Haven't had a lot of time this week to work on it, but have some ideas that I'll probably have a starter Amazon store where I'll have some of the kind of gadgets that I use to screen for vascular health at home. And then patients, if they're interested, or people who even don't work with us, they can research it, like what blood pressure monitors we recommend, what heart monitors, what nitric oxide test strips we recommend. I'll try to include them all on the store there. So I hope you guys have a great week, and we'll see you again next time.